The role of computerized tomography in early diagnosis and treatment of acute hemorrhagic pancreatitis. Hemorrhagic pancreatitis is a rare condition that is characterized by the rupture of pancreatic vessels and successive hemorrhage in or around the pancreas. It can arise as a late sequela of acute pancreatitis or as a complication of a ruptured pseudoaneurysm. The goal of this study is to report a case of hemorrhagic pancreatitis and stress the significance of the associated radiographic findings on computerized tomography scan in early diagnosis and treatment. A retrospective autopsy study found that patients with acute pancreatitis died significantly earlier than a control autopsy population. Hemorrhage of the pancreatic vessels results from necrotizing acute pancreatitis or from pseudoaneurysm, and clinical outcomes range from mild and self-limiting to life-threatening, depending on the severity and extent of hemorrhage. Etiologies include biliary tract disease, more commonly in women, and chronic alcoholism, more commonly in men. Early radiographic diagnosis and intervention improve mortality. Now we will discuss the case information. A 52-year-old male presented with constant epigastric pain with radiation to the back with onset 2 hours prior. The pain was associated with nausea and vomiting, and the patient's past medical history was significant for alcohol use disorder. His labs were significant for a hemoglobin value of 12.9 and a hematocrit value of 38.8. His lipase value was 4,000. Here we see the patient's CT scans that reveal a moderate amount of peripancreatic interstitial edema. There is a 7.9 by 5.1 cm hyperdense bilobed hematoma involving the pancreatic head, uncinate process, and the second portion of the duodenum, with a small focus of enhancement posteriorly along the hematoma due to a pseudoaneurysm. The ventral wall of the duodenum is non-enhancing and not well seen. Also present on the CT scan is a hematoma measuring 3.9 cm located more caudally at the medial uncinate process, possibly intraluminal of the second and third portion of the duodenum. There is no evidence of active extravasation. The patient was admitted to medicine, and general surgery and GI services were consulted. He was treated conservatively with intravenous fluids, bowel rest, pain management, serial labs, and empiric antibiotics. His lipase values continued to downtrend and normalized while diet was slowly advanced without increased abdominal pain. He was appropriate for discharge on hospital day 4. In conclusion, hemorrhagic pancreatitis is a rare condition resulting from necrotizing acute pancreatitis or a pseudoaneurysm. Alcoholism is a key etiology of hemorrhagic pancreatitis, and there is a wide range of clinical outcomes from mild and self-limiting to life-threatening as the severity and amount of hemorrhage varies. Early radiographic diagnosis and intervention improve mortality in patients presenting with hemorrhagic pancreatitis.